Okay, we are recording. We have representatives from Elite Home Health here. They've already given introductions, but I've asked them to do it again because they did such a fantastic job, and we need to know their names and their faces as we go out on our patients. So I'm going to hand over the stage to Amanda.
Hello, everybody. Nice to be here today, and we're excited to educate you guys on home health and how we can help some of the patients you guys may see. Thank you for having us today. And my name's Amanda. I do the marketing here in Salem, Ash Flat, Calico Rock, Mountain View. I don't know y'all's areas that you go. Y'all just cover just Fulton County. So we cover all the areas. I've got a map here, but I'm also gonna let Dalton introduce himself.
I am the clinical director here at the Salem office. So I kind of oversee the therapists, the nurses from the office here in town and kind of coordinate everything. A lot of casework in the office that goes on. Referral setup, that sort of thing.
Hi, I'm Taylor. I'm the case coordinator at Elite Community-Based Services, and I do scheduling and referrals. I run the show in the office. I train aides to do personal care services for patients.
Mm-hmm. And you gotta say everything you said before because it was
Sure, go for it.
No, it's not a short rider business at all.
I'm Sarah Rowden. I'm Director of Business Development for Northwest Arkansas. So I just drive a lot.
That's it.
I am a nurse contract, so I've been an RN for 22 years. So
Wow.
Yeah.
She's worked
for this company for 7 years.
The whole group's amazing. You guys will love working with us.
Well, talking with Kelly, she thinks really highly of you. She enjoys working with you all.
Thank you so much.
She's spicy, but
she's good. She's so
really
good.
good.
We like it.
We love spicy. Well, I'll just start out by letting you guys know, which we said this before, we do cover the areas that you guys cover in Arkansas. So what we provide is skilled nursing in the home and education. We can help with rooms, and then we also do therapy too. So give me a reason of why maybe someone would give you guys a call to come get them. Would it be a fall? Ooh, this is bad. Y'all need to reschedule this. There is so much going on right now. It's insane.
yeah.
So
Yeah. About on average, how many calls or visits do you guys get a week?
A week for like home health patients or just
No, just calls for y'all to go out.
weekly. I mean, it varies, and a lot of people don't realize that our call volume is seasonal. I mean, we're gonna have like more cardiac and stuff during warmer weather, and then like holidays, it's more like behavioral, suicidal ideation. That type of thing.
Mm-hmm.
So, of course, we're merging right now with the big Baxter Health Hospital, and their call volume, he can tell you the call volume over there is horrendous.
it's insane, isn't it?
Oh, yeah.
I see that you guys just redid the ambulances too. They re-racked them, so they say Baxter only now.
Yeah. So your 24-hour period.
24-hour period on that, we run 19 calls per ambulance.
Wow.
Where our busy day
Wow.
is 6. Yeah.
So you might do
is really
6.
busy.
It's a busy
So
day.
what are like the most common reasons you guys get calls?
Falls.
Falls.
I
Okay.
figured that probably number one.
Yeah.
So, what we do, like she said, we provide skilled nursing, physical therapy, occupational therapy, speech therapy, medical social worker.
You do speech therapy.
And now our speech therapy is, I think we have a PRN position open
So
with our agency.
Yeah.
So it's kind of spotty when our girl's been on maternity leave.
But she'll be back.
Okay.
kind of in our further area, Jones Problems is theirs too. So it's kind of based on area right now. Yeah.
But Falls would be a great one, since that's y'all's main call for you guys. And y'all may end up seeing a patient of ours. But my role in Elite Home Health is to go in and ask the providers, hey, have y'all had anybody that have falls lately? And a lot of times what you guys are seeing is probably folks that
You
they
drive the
know.
pink rig, don't you?
No.
No, you don't. Okay.
Mm-mm.
I don't know.
I don't know, I'm wondering who it's used to be,
Yeah.
okay?
Because you asked earlier if I was up for quite often, and there's a lady that let in the back door quite a bit. It's not you? Okay, well, I'll be sure if I come back here, the back door.
Oh, yeah. I usually on the nurse's side.
Okay, okay.
But I'll ask them, hey, have y'all had anyone with falls lately? Did you realize that patients, when they go in to see their doctor, a lot of times they will not even think about telling their doctor that they had a fall?
Yeah.
So that's probably why you guys get so many calls about the falls. And if their doctor does not catch that, is there any way that y'all can relate that message to the doctor? Is that something I'll do?
We
Or
generally are, what we have to do, we, through the state, we have to do what we call trauma bands, which
Mhm.
is, it's a band, it's orange, and it's got a number on it. Any kind of trauma, if it's, I cut my finger on a tuna can to, I just ran a chainsaw through my leg, we have to document that and put that trauma band on. And one of the questions that we're supposed to answer, and I myself will even say this, that I don't do it as much as what I should, is if, if it's a fall that I've been falling here lately, or even if it's, I'm just nausea and vomiting, we go out and we should be asking, have you fallen in the last 3 days? And that kind of gives you an idea of, where we're at, and the process of life. We'll just say that.
So,
yeah.
do you guys ask the patients questions, or I say patients, your clients, do you ask them, when you're in the home, like, hey, do you have any help? Are you getting assistance? Are those questions that you guys ask?
I do, yeah, especially if like the situation, if there's something like dirty dishes piling up in the sink, or there's a lot of like feces or defecation, or animal, human, either one. I generally try to ask, do you have family members? Do you have help? But I really don't know, like, we've discussed quite a bit about like advocating for children, especially. And we had somebody come in to speak today about like the family members, what the county or the state offers family members in order to keep their children in their home. So in order to keep a patient or a client in their home, what are things that we can look for that would help us know to bring
Did
home?
you have those indicators?
Well, I did bring this in here, but falls is probably your biggest thing,
Yeah.
I would think.
Yeah.
So there's something I could do is possibly even meet with you once a week and say, hey, who have you had that's had falls lately? And then I can go and do the footwork of going and getting the referral from the doctor. And saying, hey, would this patient benefit having home health and doing physical therapy? That might be really good because their insurance pays that.
Get patients before they're falling, like when someone's noticing like a shut gait, you're not picking their feet up. That's the goal, but most of the time, it doesn't happen that way. Usually people wait till the patient has fallen and injured themselves before they refer our services. Our goal is to be more proactive in the community, again, educating about our services, what we do. Falls is huge. That's, every patient, there's just, but when they say you're one fall away from a permanent address change.
Yeah.
That's so, our goal is obviously to be more proactive, but even if, say, y'all get a call on, like, for some chest pain, that the patient didn't meet the criteria to go to the hospital and be admitted, but you think, okay, I have concerns about this patient, like what happens to the patient once you leave? So the patients that kind of give you like that feeling like, oh, they could use some additional follow-up even though they didn't qualify to be admitted somewhere. Those are the patients that really could truly benefit.
Yeah, and I've asked patients too, like, what's going to happen after we leave? Like, are we just going to sit here, or how are you going to get to bed?
That's exactly right.
Yeah.
That's exactly.
Yeah, our focus is of course the geriatric population, Medicare aged population. So as far as services being covered, Medicare pays for our services at 100%.
Wow.
And
VA,
zero copay.
Wow.
And I did bring those payers for you guys too.
Okay.
So you guys can look at that.
Some of the difficult difficulty getting primary care to sign off on it though, because I have that issue with grandma. Because without the primary care signing off for her to get in home health, they wouldn't be able to come out.
So for skilled service, so there's skilled services and there's non-skilled services, that Taylor, she works on that side. So for us, like we have what we call like inquiry forms, like a referral form essentially, to where like if you give us the patient's name, their phone number, and like the primary care provider and I think their date of birth maybe, we can follow up with PCP and say, hey, you know, Emma thought this patient could benefit from our services. You know, they've been out on a call and the patient, you know, had whatever going on, XYZ, you know, would you be okay with us going to see the patient? So you know, we have to have physician's orders for everything that we do. We cannot go out to evaluate without an order. And most of the time, the physicians work well with us when we do call them, most of the time.
Especially here in Fulton County, I would say most of them are all pretty familiar with what we do and the services we provide.
Yeah.
Kind of looking at what a home health patient's looking for, I have like a little list of indicators. So if they're like have a new or an exacerbated disease process that they're struggling, maybe they don't know the signs to report to their doctor, they're letting their blood sugars get out of hand before they call you guys.
Yeah, that's a big one too.
Yeah.
Well,
So that's something you think, well, maybe home health could help educate this family, this patient.
We can go in and just educate.
Yeah. If you're noticing some that are really confused on medications, we're able to go in and do all that education with them. We're even sometimes able to help show the families of how to fill a pillbox planner each week and get them comfortable doing that themselves. They're not able to do that. Sometimes we're able to find different pharmacies and stuff that will do the pill packs. Same thing to keep that straight. That's a big thing with home health. Of course, teaching pretty much most diagnoses you can think of, like would be beneficial. They know what's going on with their body. They know the risk factors. They know the symptoms. We can nip things in the bud at the very start. It's going to prevent them from going to the hospital. So that's kind of our goal. That's home health. So when we're calling you guys and stuff, we're like, oh God, but we're worried about them because we don't want them going there. If they're back and forth, this says from the MD office, but if you guys are noticing you're going to the same house throughout the week, what's going on with that patient? And would extra assistance in that home maybe cut down the frequency that they're having to call you guys? If you're bringing them to the hospital multiple times, if you're noticing like maybe their home environment could be set up better to prevent these falls. Now, we have to make sure that the home is safe for us to go in and take care of this patient, but if we're able to make that environment safer for that patient, we will.
What about hoarding situations?
That would be more aid stuff. Like if their pathways aren't clear, our aides can go in there and help them clean up the home and clear those pathways to where it's safe for the nurses and for the patient.
Okay.
We're able to help them, like, let's say they need some DME equipment. We go in there and identify like the missing DME equipment that will make it safer for them to get in and out of the shower or the bedside commode, something like that. So we're able to communicate with that doctor and get the ball rolling on that sort of thing too. New oxygen's kind of going, like we have our own clinical program for like COPD and kind of anything under that umbrella. We've got like a rebreather that we teach these patients on. So it's really COPD, diabetes, heart failure are kind of our big three bread and butter diagnoses. I mean, there's so much to each one of those. We have our own little program for each, whether it be therapy or
There's chronic diseases that, you know, most of the time they landed in that situation due to non-compliance. You know, most of the time they're still a little non-compliant, you know, when we go, but I will say that even the non-compliant ones are just a little bit better while we're there. You know, when they know that we're going to be coming in and, you know, educating on their food, looking in their pantry, making sure, and then, you know, is it just they straight up don't want to do what they know they're supposed to do? Is it a knowledge deficit? Is it a resource issue? You know, is it that they're not eating properly because they don't have the resources? So that's when we would bring in the social worker and try to get them assistance in that way. So once we get in the home, you know, even if say we get a referral for the patient that's falling, that we put physical therapy in the home, physical therapy goes out. If they evaluate the patient and determine that the patient has a wound that needs to be taken care of, well, then we're going to call the doctor. We're going to get that taken care of. If it's a resource issue, we're going to call the doctor and see if we can get social work in there. So once we get in the home, we can cover all kinds of things.
Okay.
And then we're, I say like kind of all inclusive. As long as the doctor is okay to give us the orders for what, the patient needs, then we can supply that.
Okay.
We do, we do a lot of in-home like IV therapy, wound therapy. Those are kind of like what most people think of, skilled home health does. They do, wound care and IV therapy. We go in, we do injections. We do lab draws. We can do almost anything in the home, which was surprising to me because my background before home health was critical care.
Yeah.
I worked in open heart units, so I thought these patients are fine. Like, what do they need? So my eyes have been open over years.
Yeah.
But once we get in there, we try to help them any way we can.
Yeah.
So.
And Mike, you had talked about, was it your grandmother? Does she not have a PCP
She didn't
or?
have one, and so they would only sign off on it every so often when they thought she.
Yeah.
And she did it more often before they would sign off.
Right, okay. Well, we do, Dr. Homer Brooks is our medical director.
He's so good.
He is wonderful,
Yeah.
and so if we do run across patients like that, we have referred those patients to him because he will make house calls. So,
Some of your bad issues, like that, provider with the patient has, just like they've been with them for years. And the problem is they push that down now to switch providers, and then the new provider doesn't know virtually anything about them. And so they go months and months and months without the proper care that they actually need, because the family wants them to have different care than what they've had. Maybe they didn't have a perfect care provider, but that care provider knew more about them and whether or not their conditions and health conditions were going to deteriorate rapidly than the new provider they have that evaluates them every 2 months for a long time because they don't know anything about them.
that's
And
exactly.
we have to have tough conversations with the patients and their family members sometimes,
Oh, yeah.
they're impacting us being able to take care of them or other providers being able to take care of them. Those are, we let the old director do that normally.
Yeah. Yeah.
So a question that was proposed is, you were talking about coming up and asking about patients that had recent falls. Is that a HIPAA violation for us, since it's, the closed loop of continuity of care? You can only talk about patients and certain people in that. Would it not be better if we leave forms with the patients and tell them that their insurance most likely cover the services that they need and that they need to talk to their doctor for them to call you all?
I believe that it would be fine for you to ask the patient. It's fine to leave our information with them,
Yeah.
but I believe if you asked them if it was okay to do that,
Okay.
then, as long as you have their consent to do that.
And even family members can do this inquiry form too, so you could even leave that there with them.
And you
and
can
have
show them
them
what it
reach
is.
out.
But it's,
Okay.
a lot of times it doesn't start with a doctor's order. A lot of times,
Yeah.
hey, I think this patient could benefit, and then we do all the legwork to get it done. Which doctors
A number of them printed out.
even when we get a referral from the hospital, that's the hospital that's saying they need home health. Well, the hospital doesn't sign orders.
Right.
So we then have to call their PCP to say, hey, this patient got referred, are you okay to sign?
Okay. So that's the ultimate. Okay.
And say y'all just recognize falls, since that was a big deal. We can always add a nurse in after, technically we like to do nursing first.
Yeah.
But if it's falls and we dig into their stuff after we get the referral from their PCP, then we can say, they would really benefit from having nursing and therapy, and then also possibly an aid service. Taylor, if you want to talk to them a little bit about your aid
So-
service.
The falls. My brother is administrator at the jail, and he told me about a guy that he calls you guys to come and put him in the vehicle because his wife can't get him in there, or he's constantly falling down. That's an aid service. We can help with those. Like, if they fall, most of the time we can get them up out of the floor safely. That's what they're trained to
That's
do.
here on North Main, isn't it?
And we're actually in the same office as.
No, I mean,
Actually, no.
No. Okay.
This guy's way out in Glencoe somewhere, but
Okay.
but he's constantly calling to get this assistance.
Yeah.
Our aides can help you get in and out of a car. We can help you get up and down from a chair, whatever, obviously we can't do every little thing. If you're on the floor and they can't lift you, then we're going to need that help. But 90% of the time, if there's an aide there in the home, they're not going to be falling quite as much because somebody's there to help them get up and down.
Yeah.
We don't need an order from a doctor to start services. As long as their insurance covers it, or if they're willing to private pay for it, that's something that we can do as well.
So are you the first step then? Like which I mean, like after you get the doctor's orders and the patient's evaluated and they need these services, are you like the first one that goes in and after evaluation?
Yeah,
to
I think
help,
it really
sometimes
depends.
they may
We
get a
send them
referral.
patients, they send us patients.
Yeah.
It's back and
Oh,
forth.
okay.
It just depends on who gets the referral and what need is needed.
Yeah.
So
So we always kind of we'll get referrals that are sometimes confused. So you think home health, you think that we take care of the home and stuff on the skilled side. No, we're strictly medical. So their side is the more, hey, let's help prep, meal prep. Let's do
meal
that.
services.
Yeah.
You know, if you have a patient that's got bad nutrition, let's get an aide in there that can help them with that.
We see that a lot too.
Yeah, or they can't clean up after themselves, or they have incontinence. You know, a lot of our stuff is going to be revolving around personal care stuff. Any kind of grooming, showering, incontinence stuff, meals, med reminders. That's a big one. You know, I'm dizzy and stuff, or I've forgotten to take my medicine, or I've taken too much of my medicine. We can't mess with the medication. We're not in there to do that.
Right.
But we can remind them, hey, did you take your medicine today? Or hey,
Assist.
are you sure you haven't already taken your
Yeah.
medicine today? Because that's a big thing too. When I've noticed a lot of our clients fall if they've taken too much or not taken enough of their medication. And then I think like I said, we don't need the referral from the doctor. And of course, if we go in there and we're like, oh my gosh, this is way more of a skilled service, then I'm gonna go over to Dalton and I'm gonna say, hey, this is what's going on in the home. This is far beyond our realm of what we can do. Can you help them?
Most of the time, if they are needing their services, you know, if they can't get in out of the car, well, then they probably need some PT to help them, you know, again, take them outside. And, you know, let's work on this car transfer. Let's work on, because when they're in a hospital or they're in a clinic, you know, they've just got great even level floors, all the same, you know, they're not going from, you know, with big thresholds of, you know, like linoleum to carpet. And because that, you know, say it's a diabetic, you know, they can't feel their feet. Well, when the flooring changes, they're more than likely going to fall.
Yeah.
When you can't feel your feet. So most of the time, if they need those services, then they also need our services, because our goal is to get them to where they can do things independently or as independently as possible.
Yeah.
Now, you know, a lot of people are like, well, this person is old and frail. They need a nurse. Well, old and frail, Medicare does not think that's billable. So, and our billing, you know, as far as the coding is way different than like clinics and outpatient is concerned. You know, like falls is a great reason to refer a patient for home health, but we have to know why. Why are they falling? Is it that they're diabetic and they can't feel their feet? Is it that they have CHF and they are getting short of breath? They're getting, you know, their O2 sats are getting lower. You know, it's kind of like the reason why they're falling. So we have to kind of uncover that to get the right diagnosis.
Terry actually mentioned that. She said a lot of falls come from CHF and diabetic.
Yes. So, I mean, because those are, you know, the big comorbidities that you see, and that's the big focus on, like readmission rates, and those are the biggies. So we do have programs developed around those specific disease processes. You know, like our CHF patients, we're weighing them every time we're there. We teach them to weigh themselves. We provide a scale if they don't have a scale. We provide a talking scale if they can't see a scale. We're measuring their ankles now every visit.
For like cellulitis and fetal edema.
Just to identify, you know, again, are they getting fluid? Maybe they don't have the weight gain yet, but trying, you know, everything that we
Looking
can.
for any of those micro changes that we catch early on.
Okay.
It's easier to call the doctor like, hey, we need extra diuretic for a few days, rather than them being so fluid overloaded. They're calling you guys.
You know, and they have oxygen this time of year, especially, you know, you've got, you know, wood heat and gas heat. So, you know, we don't want them to, inevitably you'll walk in and they're over there trying to start their propane heater with oxygen on. So a lot of education. That's what we do mostly, is educate. And again, try to teach them how to manage their disease, you know, independently.
You said the hoarding. We do light housekeeping. And then, you know, as far as the hoarding goes, for us, we can kind of pass that off as the light housekeeping, because it's a fall risk. It's a big
Yes.
fall risk. And that's one of our bigger ones. I have a lady that's,
And a fire hazard.
yes.
And, you know, an escape
Mhm.
hazard.
Yep. I have a lady obsessed with Temu. She has Temu boxes all in her doorway. Their social worker called us and was like, hey, can we fix this? And we're in
Yes.
there trying to get that done right now. But that's a big one for us, is trying to make sure that they have all of those precautions in place, is to making sure that they're not falling a lot or getting trapped in there because of a house fire or whatever.
Yeah.
Yep.
We deal with a lot of animals.
And then I'll kind of talk a little bit about things you kind of help us with. So it wasn't long ago that I had a patient over in Cherokee Village that we went out and admitted. Something just wasn't right with this caregiver situation. So we had taken them on. We had seen them a couple of times. I guess there was some domestic violence or something that happened in that home. So actually his daughter and him went and stayed in a hotel nearby. Well, I had called and kind of talked to EMS over in Highland, and they went over there with an officer and stuff. And that EMS was just excellent. He sat there and talked with that patient. A lot of times we would get someone come out there and be like, it's not really an emergency, why is EMS here? But they identified that this daughter was not bringing them to the emergency room because, or bringing them back to the nursing home because she was cashing this check fraudulently, wanting them out of that nursing home so she could have that money. So we were able to get that patient into the nursing home, identify that, and I think the daughter got arrested for it. So sometimes when we're calling you guys out to the homes too for those new situations, or we can't leave that patient there unsafely, just kind of thinking around the box in that way. How can we collaborate together? Maybe we could both put in an APS report, just where there's multiple sources going out. Hey, this patient's not safe here.
So I'm gonna call you out. Because we were actually talking about this at lunch. He works in Baxter County for mental health. He was it APS that you were talking with? He said on a patient that he went out on with pretty regular, he was calling APS, and the person receiving that report, actually, how many times did you call? Told him not to call anymore on that patient.
Yeah, you can call Little Rock at that first.
Yeah, I'd be requesting a supervisor for.
I've had to call Little Rock.
We've had to do that as well.
It is. You've got to drive them so crazy that they pretty much beg you not to. So
Okay.
the
Can
more-
we get a hold of y'all and y'all help us with that? Is that an option?
As long as we have orders to be in the home and be, for the patient to be on service.
Well, I just meant to get connected
Oh.
with.
With APS, like the
Whenever
Little
you
Rock
do a APS report, you're supposed to get an email confirmation from them, and it has their supervisor's number at the bottom of that email. If they're not emailing you, that's a whole other issue, because that's part of what they have to do whenever a report is submitted.
Okay. So is that telephone or is that online?
Both. You can fill out the mandated reporter form online, and you can directly go to the email, or you can call them by phone as well.
That's probably something I need to look into, because I did a video on mandated reporter for children. So I don't know if it's the same portal or if it's a different portal. I
and
imagine.
those homes are always so challenging because you want to help that patient.
Yeah.
But at the same time, is it a situation where it's hard for us to go in because maybe the caregivers are violent and stuff?
Yeah.
I can't put my staff in that
Yeah.
in that
Yeah.
situation.
Yeah, of
Um,
course.
Then you also see little patients that maybe need a higher level of care than home health provides, but we're good at identifying that.
Yeah.
And then getting them to the right place once we do that evaluation. So,
Good.
yeah.
Like they may need swing bed,
Yeah.
for a while, and then, come here for a while, get more intense
PT,
therapy,
yeah.
and then go home, and then home health can work with them a little bit
Okay.
better and more safely.
Mhm.
Because we have to worry about the patient, like, once we leave,
Mhm.
can they get to them in the bathroom? Can they transfer? We can't leave patients that can't transfer.
Yeah. Yeah.
Unless they have a caregiver, and sometimes those caregivers are combined.
Yes.
Yeah.
Yes.
So, and trustworthy caregivers.
Yes.
Another thing about, do you have more questions?
I do. Go ahead.
Oh, no, go ahead.
Okay. So I think I know who you're talking about. Go ahead and go. In a situation that we ran into, the patient was falling a lot. There was help. There was usually every time that we were out there, there was an aide there because he wouldn't call. And so the aide coming out would call 911, and we would get out there and we would see that this patient was very valid and needed help. But he could tell us, we've got 4 identifiers that we have to go along, which is person, place, time, and event. And he could tell you all these things. Now, he may be talking about space aliens that landed in the yard last night. You know, we're shooting lasers through his brain. But those 4 questions were answered. Well, that's assault and battery and kidnapping if we take him in that situation. So how can we bridge that gap between you all and us? And it wasn't y'all, it was a different home health agency that just got downright, I wouldn't say spicy, I would say naughty with us, was very upset because we couldn't do anything with that patient at that point in time.
I've had something like that pop up just a couple times. Being on the receiving end of that, like one time I had EMS come out, I don't think it was you guys, but I kind of felt like the way the framing with the patient was that they were talked down or talked out of going. So that frustrates us when we see something like that. Like, we're licensed professionals too in the home. So we're calling you guys, we really are worried for this patient.
Yeah.
So to see something like that, I could see frustration rising. But at the same time too, we understand that we can't force a patient to that sound of mind to do what they don't want to do.
Yeah.
In those circumstances, I mean, it just takes a lot of collaboration, a lot of really good documentation.
Yeah.
And communication with the provider. You know, and again, reporting, you know, calling EPS, and a lot of times it takes multiple calls, you know, in order to get them to take action.
And now calls the Little Rock, apparently.
No.
Sorry.
Sorry.
Yeah. I mean, I had one lady years ago that we knew that her son was, you know, neglecting her. We knew that there was financial abuse going on. I mean, our aide was there when the son called us and had my mom on the phone. He's at the bank, like, we knew, and I can't tell you how many times we called. And I finally called a supervisor in Little Rock. They came in, they got the lady admitted to the 6th floor, and the son ended up getting arrested. But it took multiple. I'm like, we know he's leaving her by herself. You know, our therapist showed up. She was naked in her bed with only a sheet over her.
How sad.
He had taken, you know, apparently she'd had an accident, so there was no sheets on the bed. Just, it was terrible. But it took multiple calls. Yeah. And again, me calling Little Rock to get it moving back.
I feel so like that where whenever you can't take them because they're local area from school, even though they're talking about strange things, you can't force them to go. However, when it's family there and family doesn't know what to do with them, there is a situation where a family can talk to their care provider. Family can, in that situation, with collaboration with the care provider, get either a doctor's order hold on them, or they can get a court order hold on them until someone else has power of attorney who can be admitted there.
And we've had to do that with ours before, is try to get a family member as the POA just to get some help.
In your phones where you see some of that, because the older people falling, they can have rapid onset dementia after falling in 3 to 6 months.
And we do have a dementia program as well. And it's very helpful, especially when it gets darker earlier, you know, the signs pick up a little bit more. They go in and see their provider, and the providers really like that. Well, that we have that program. We are a little bit unlike any other home health because we do have that pathway of that.
Sometimes I'll also notice, like, if the patient's refusing to go to the emergency room with us too, sometimes we'll still call you guys to come out, because, like, I think not even recently they was having chest pain and stuff. I know you guys have the EKG machine and stuff, so sometimes things that you can do can convince that patient to go that we can't do there in the home. So sometimes it's also that kind of situation too, where we're trying to do everything that we can to get someone, or just to get another professional in there to check on this patient. Because a lot of times we call that doctor's office and they tell us that patient needs to go to the emergency room. So that point, we have an order to call you guys.
Okay,
So,
and it's more documentation too.
Yeah.
It's always, it boils down to a paper trail.
Yep. That is
Yeah.
exactly right. Well, I know you guys have probably heard about the lady that passed away right behind Town and Country.
I was there.
Really?
Yeah.
Yeah.
You know, that would have been a prime, you know, patient for us to educate her if it was a space heater. I'm not for sure what happened, but
Yeah.
people are gonna use space heaters right now.
Well, I just
And-
assumed, and this is terrible, because I knew she had Dr. Brooks as her primary care because we had talked about home health. And I just assumed she had home.
I don't know if she did.
Sometimes people that
not.
need it the most.
Are the ones that will refuse. You know, a lot of
And
times they have this
Okay.
misconception that we're gonna come in and we're gonna be like, well, you gotta go to the nursing home.
Yeah.
Like, we're completely, you know, opposite of that. I mean, like, sometimes that's where the patient needs to be.
Yeah.
But our goal is for them to be home.
Yeah.
That's how we do home health, right?
Yeah.
But there is a very big misconception that we're gonna go in and be like, well, they need to go to nursing home. So a lot of times those are the ones that will refuse most of the time.
and
Okay.
sometimes it is that situation. Like I know that patient, she was on and off with us actually.
Was she?
Yeah.
Okay.
But it was really just a lack of caregiver involvement and stuff there. And we did all we could to try to get her to a different place, but at the end of the day, she wanted to stay home.
Yeah.
So space heaters made me think of a patient that I got in Calico Rock one time. He had a big burn. We get the referral. I go out one weekend to evaluate, and because they're like, we don't know how I got this burn. Well, it was like a perfect square, and I got in his bedroom and he got a little heater.
Oh.
He's like third-degree burns. It was terrible, but anyhow, one thing our therapists will say is that they can't prevent the patients from falling if they're drunk. So, you know, we've got to get the underlying, you know, alcoholism taken
Yeah.
care of. I'm like, well, can you just go early in the morning? They're like, no, I was just trying to think outside the box.
Yeah.
But you know, we can't fix that. We can't fix those falls if they're falling because they're drunk.
Yeah.
But that happens a lot. But anyhow, the heaters, this little man had been drunk and passed out on his heater. So.
Yeah.
Lots of people need our help out there.
Yes.
We'll be glad for any leads you guys can give us.
Okay.
We have openings all the time. We have RNs, LPNs, physical therapists, OT, speech therapy, I kind of told you all that. And then also we can send the referral to Taylor and her team of aides. And we can be in the home at the same time.
Even we work with home health, we work with hospice, you know, we can be in the home at the same time. That's a lot of people.
So we're
So you were in
primary.
hospice too. Okay.
Yeah, we're primary care through their insurance, and you guys are secondary and private pay. So
Private pay, and then there is quite a few insurances that pay 100% with no copays as well. Medicaid is a big one, and VA, WellCare, Blue Cross, and all the past programs as well.
So the bigger ones.
AR choices, a lot of clients, you know, if you notice that they have a family member that has dementia and they do have a caregiver in the home, maybe they need a break. Maybe they're exhausted and their dementia clients getting up all hours of the night. That's a perfect time for an aide to be in there to let that family member get some rest.
Yeah.
oh, absolutely.
Yeah.
Absolutely.
Got some questions. I think that if a family member is told that they can get help without costing them money, some would be willing to contact home health or a doctor more willingly. I would love to have forms on the ambulances to hand out from Elite. Yes.
So include that fees that they give us, we just make a bunch of copies.
Yeah. Yeah.
And those, I mean, we have 29 locations in Arkansas. So you may have family somewhere that needs help. You know, and if you're in Baxter County and that's the only form you have for Salem, it's fine. Send it to Salem. Salem will send it to our Mountain Health
We
office.
bounce off of each
Yeah.
other all the
Yeah.
time.
All
And our aid services cover the Baxter area as well.
And Calico Rock.
Yes, we are all over. We cover, you know, all the way to Pocahontas, all the way to Yellville and Newport and Silver Rock area. So
So I'm gonna use your situation again. Say he had home health and it's different than Elite and he's calling he's calling to get help, APS or whoever, and he's still not getting that help. Again, can we call? Is there anything that y'all could do to help bridge that, or do we just take call over?
If they already have a, like, say they have, trying to think, like, medicine services area, Spring River services area, Centerwell, those are some of the other home health providers. So, I mean, if the patient has that service and they're not happy with that, then we can, yes, go to the physician. We have to ask, I mean, the patient has to sign a form that they want to transfer, because we're not shady. We're a very, very ethical company.
Yeah.
So again, they can sign a form that they want to transfer or switch agencies.
Yeah.
Because that agency has to discharge before we can ever go in to evaluate.
Okay.
But if you just have questions in general about home health and your home health needs, I've got my card here.
Well, you're about to get about 22 besties.
So
Be careful.
There we go.
this is my personal
That's our
number. I
girl.
don't, yeah, the cell is my personal number. I have a work phone, but I don't give that number out because I don't want to keep up with calls and texts from
Two different phones.
two different phones. Yeah.
Yes.
So if we
And you
get
have
their
my
address,
cells.
if we can get their address and just write a brief description and give that to you, will that work?
An address.
We need the name.
Yeah, we have
address,
and
and
Yeah,
then-
when we go to the provider, we have to have name it first.
Well, I had that question too. I thought like if Kelly, since Kelly and I are good friends, and I said, hey, we went out on a patient at 185 Wildberry. We all know 185 Wildberry. Can somebody go out as a representative and talk to her about home health services, or?
So kind of like we touched earlier, everything we do is order driven by the
Okay.
physician.
So it has to come
We
from
can't
the-
just cold call patients.
Okay.
It's not legal.
Okay.
Now, back in the old days, it might have been, but.
Yeah.
If you guys talk to the patient, be like, hey, there's no physician order for it. If you just, I'd like for you to hear about their services. If
Yeah.
the patient is then okay with that, then we
Okay.
can just talk to the patient, but we can't just.
And then we can document it on our
Amanda
end,
could
counsel.
they could call Amanda and say,
Okay.
okay, or they could call about, and they could just, again, explain what we do.
Okay.
Yeah, because a lot of people, I mean, I've had patients call back, can you come mow my yard? Now, I will say, we have mowed some yards before, but it's because the nurses couldn't get in.
Yeah.
We do haul firewood, we do it all. But,
That's right.
so there has to be medical necessity in order for Medicare and Advantage plans to pay. So, they request documentation and review it. So again, there has to be a skill. Again, that's education, assessment, observation, teaching, wound care, complex wound care. So there's a number of things. Now, therapy can go in, we can work with these patients, so we can get them to a certain level. And once they get to, once they start plateauing and they're not showing any further progression, then it's very difficult to justify, Medicare paying for a therapist to come.
Yeah.
If that's as good as they're gonna get.
Right.
That's as good as we can get them. So, we have people say, well, they still aren't, they still can't do this. Right? We understand, but medically, medical necessity is a big deal.
Yeah.
Medicare, they don't like fraud.
Yeah.
So again, we have to be able to justify medical necessity and the need to not only to start services, but to continue services.
Yeah.
So
I'm just thinking I'm doing something wrong. The lady from DCFS was telling us her, to help their families, they go and help get money for roofs to be put on their houses and stuff, and y'all mow yards.
No, not at all. Not at all.
I have a lady's dog now. I'm volunteering to keep the dog.
Oh,
2 weeks to 30 days while she went to rehab.
2 weeks to 30
Yep,
days.
It's been a year and 2 months. Passed away.
Oh.
So, that was my last good deed.
And I do want to touch on this. Sometimes we will get the patient safer therapy for no goals, and we get them to their goals. We discharge at that point if they're, we can see that they hit all their goals, if they're good. Sometimes they may get back where they just sit, and then that therapy is lost. And it's kind of like anything else, running or walking, you've got to work at it to keep it up. So the doctor will reorder home health for that patient, and that is fine too.
Okay.
So, and that's something else, that's a great thing to educate patients on. They'll go, well, I had it before. well,
Yeah.
they hit all their goals and then maybe they decline and they need it again, and that is okay too.
So when
Still
y'all go
depending
out,
on their insurance.
there should be like a folder in the home that has like, our information on it, usually like a magnet on the fridge. Saying that that's a good indicator that we are either in the home currently or have been in the home.
Yeah. Yeah, generally, I myself try to look for that at least to see what agency, that way I can relay it to the ER.
That is,
Another question that we had is, are VA patients accepted?
absolutely they are, yes.
All veterans.
100% on both sides.
On both sides.
Mhm.
Good.
Yes, we strive to take, the best care and get the most care from the VA. There's a few obstacles we have to run through
Yeah.
and jump through.
Of
But we
course, it's
will,
VA.
but we will.
I think I almost
do
rather
it.
call ITS, but
On
Yeah.
on the
Yeah.
VA.
Yeah.
But,
we need authorizations. We've had this referral for 2 weeks.
yeah, sometimes it takes up to 2 weeks to get that off. So one thing I do is, once again, go in there and remind those providers, hey, we take VA. If they're shuffling in here, please let us know. Let's start the process, because it's gonna be a couple weeks in that patient, because that could have already fallen in that 2 weeks while we're trying to get them stronger. And then you also have some veterans that they serve the country and it's very hard for them to accept help.
Yeah.
That's another thing that we come across.
Yeah.
That the provider will say that to them, but they're like,
Oh, I've seen it time and
know.
time again, with like the chainsaw and their legs falling off, and I don't want pain meds. Well, I can get my box, my happy box.
Yeah.
That'll make you feel a lot.
Yeah.
I don't want. Like,
yeah,
okay.
you don't have to be tough right now. We're
Yeah.
here to help you, because if it wasn't for you, we wouldn't be where we're at.
Yeah.
So,
Yeah.
absolutely. VA, we try to help everybody we can. Humana is
The only
very
two
hard.
I think it's easier to tell you guys which insurances are very difficult for us to take.
Mhm.
That's Humana and Medicaid. Those are the two that we have the biggest
And
problems.
Medicaid is no problem for us.
Medicaid, so
Uh-huh.
fine with her.
Yeah.
So Medicare is okay,
Medicare,
Mhm.
VA,
but Medicaid.
And
correct.
Medicare is not paying on.
Isn't that crazy?
Yes.
So I have
So
that here for you.
Medicare,
Okay.
VA services are like a lunch.
Okay.
Yeah.
Terrific.
Zero copay for us.
They are
on
not
these.
doing no
Okay.
non-health stuff. Most of our Medicare patients that we
No.
have a Medicaid
Fine.
secondary plan or plan.
Awesome.
Upload it
Thank
to
you.
the class, whatever.
Okay, I sure will. I sure will.
And I brought you guys some brochures for us too. We are not order driven by doctors. So if you feel like there's somebody that's falling or whatever, if we go in the home and we think home health is needed, then we'll call the doctor on our side and have it sent over to them.
So are you elite too, or are you?
Yeah, so we're the community-based services. We're sister companies. to
Okay.
them.
Okay.
I am doing Kelly's old job.
Okay, all right.
I'm not
Doing
normally
a
the
great
talker.
job.
I'm not normally the talker. Militia is for our office. I am the behind the scenes guy that will talk to you on the phone all day long, but
Yeah.
public
That's how
speaking
I
is not my
am.
thing.
They're
Yeah.
like, you're so extroverted.
Yeah.
I'm like,
Oh,
I'm
no,
not.
you did great. You did great. Thank you for having us.
You're welcome.
Yes,
We
Thank you for
really
having me.
appreciate the opportunity to educate you guys, and I know it can get, lost in the mix, but if you want me to touch base with you, I'd be glad to.
Yeah. Also awesome to hear you guys' perspective as well.
Yeah.
Oh, definitely, definitely. Did y'all have any more questions for us or anything?
So, like, if we went to a home, they got your little sticker. Is it all right to call that nurse, whatever nurse, and say, hey, we're here,
Uh-huh.
they fell, we picked them back up, just so you'll know?
Yeah, and we have an after hours.
Is the after hours usually in the packets? The after hours?
If you dial our number, it just rolls over to the on-call.
Does it
Yeah.
really? Okay.
Usually,
24/7.
after hours, you'll settle there for a second, they'll take your message, and then they'll relay that message to whoever's on call that evening.
Okay.
So, 24/7, no matter what, there's always an RN that's going to be on the other side of the line to eventually see that message. We try to respond within an hour.
Yeah.
So, yeah.
So I have a question for you guys. So do y'all ever get patients that have the, I think we call it a peers, but I don't know what you guys would call it, but like
Oh, tons.
you do? Okay.
Tons. Yeah.
Do y'all get those calls ever?
Mm.
Okay.
Yeah.
You do?
Yeah. Usually when it comes to our dispatch, they give us the address.
Yeah.
and they'll
I
say,
believe
Yes,
that.
and they're
mail
like, what do you
order.
get?
Okay.
And we're
Mail
all,
order.
"Oh, I'm gonna sit here. Well, what
And
is
they'll
it?
tell
It's on
us,
the
there's
kitchen
a
table."
key.
Oh, good morning.
Okay.
Okay.
Oh my goodness.
Oh, okay. Good deal.
Yeah.
Good deal. That's great.
Oh,
yeah.
oh, wow.
So,
We
in
had a guy in Fulton
Yes.
County that would call us frequently, and he would call 911 frequently. And then, like, once he got the, okay, we're on our way, he'd be like, oh, can you stop getting a cheeseburger?
Yeah.
Just hungry.
So I'm going to ask this. I've got a question, but to be sure we're not wasting anybody's time. Everybody's time is valuable. If you have any more questions, go ahead and get them in. And maybe after I get through with my questions, we'll get to y'all pretty quickly. So my question is, a lot of times we get called. We've got one lady that I swear to goodness, bless her heart. The last time I went out on her, it was a fall. But she was laying on a heated pad and she had her little space heater right beside her to make sure she didn't get cold. And she had blankets over the top of her. And she's on the floor. So that to me is not a fall. That's I think of a fall. Yeah, in the kitchen and I tripped and I'm inconvenienced. So I'll say it that way,
Right.
as opposed to making sure I'm comfortable before I call 911. So I consider that loneliness because she does live on her own. Do you have services for that?
Companionship.
Companionship.
1000%. You know, we
Okay.
have a lot of clients that have had suicidal ideations or they're alone. They don't have any family here. 100%. That's what our companionship is for.
Okay.
Yeah.
Sometimes I feel alone.
Drive around all day.
I'm giving my maybe a couple of kids loan on my husband and they
I've got a teenage son and a preteen daughter. I'm like,
in all seriousness, that is a great thing.
Yes.
And sometimes that can lead to depression. and
Especially
maybe
during those
anxiety
holidays.
or
Yeah.
something like that. And we collaborate really well together.
Yep.
So
Good.
we'll try to
Okay.
get them, we'll look at their insurance and see what all they qualify for.
Yes.
You know, we try to stay at home as long as we can, adding those disciplines and, how else can we help this patient?
Yeah.
So.
Well, that's great news because that's a lot of our calls.
Mhm.
They're just, I've heard stories before too about a gentleman that I don't think he was from here. I think he was actually from Baxter County. That he would call 911 around lunchtime because he wanted a sandwich.
Oh, right there's your patient
Right there.
Yeah.
for Taylor
prep.
for sure.
1000%. Yep. Yeah.
Yes.
We, like I said, my brother is the administrator down here. He calls me and he's like, hey, can you do this for this one? Yes, that's what we're here for. We're any kind of daily living activity. If they can't do it, we can. So
Okay.
it's just the process of getting them qualified and seeing what we can, how long we can be there and what we can do for them
Okay.
or what they'll let us do for them.
What's y'all's turnaround time?
Medicaid has 15 business days, so that kind of sucks. VA, usually I'm getting a referral from them, so I can start them immediately, private pay immediately. Air Choices is immediate. Most of our Air Choices is going to be those dementia clients.
Okay.
It's a very hard, I'll tell you that. I've been, we have somebody that it took them a year to get it for their mom that had dementia. It was really hard to get, but she
Oh.
finally got it. And it's good to have
the
her
PASS
as a
program.
program. No, it's
That's that
just filling it.
Medicaid
It's
you're
a,
talking about.
so yes,
Yeah.
it's a, I don't know how to explain that really. It's not a PASS program, but it is a Medicaid like commercial program that they
And
have.
that's so odd because PASS is for kids, and I mean everybody knows PASS for kids.
One thing I learned, I don't know, it's probably been 3 to 5 years ago, I lose track of time. I called before, actually it was probably before y'all came along, or was it a patient that y'all didn't service that territory. So I'm like, patient has Medicaid, let's give them some, non-skilled help. Little did I know there's 52 different types of Medicaid.
Yeah.
Holy cow.
There is. You would
I
be
mean, they got
surprised.
Medicaid, why can't you, maybe it was transportation service. Yeah. They had Medicaid.
And we can help them with
It has to be a
transportation.
specific Medicaid.
You can.
Yes.
If they need
Verida,
transportation
which is
services.
Medicaid's transportation service, will let our aides sign up
That's
and
the
be
best.
drivers for them.
Okay.
So our aides can now sign up through Verida and be a driver and take their patients to appointments.
Good to know. Very good to know.
Be a driver. Do your aids.
Light housekeeping, companionship. Come on.
That's what I'm saying. We're
The best
doing
of all
something
worlds.
wrong. I could have used a new roof a couple years ago.
Yeah.
Shoot, I wish.
Yard mode, yeah, doing all kinds of things. So, all right, I don't see any questions in the Zoom room, and I don't know what it looks like. It's vibrating. We'll see. We will see. Oh, nope, it's all the other ones. Okay. All
Thank you
right.
guys for having
Thank
us. We
you.
appreciate
Thank
your time.
you.
It was nice to meet all of you. I used
Yeah.
to work here. I worked here for a long time.
Where
so
at?
I was a biller for 4 years here
So you stayed hold up in your.
with Shara. Do you know her?
Uh-huh.
Yeah. Her and I
Yeah.
shared an office together.
I was
Okay.
raised in this hospital.
You were raised?
Yeah,
in
my
this
mom worked
hospital?
here as a LPN respiratory therapist, RN, director of nurses,
Who's your mom?
Nancy Daly.
It's today.
Little short blonde firecracker.
Hard to forget.
Yes. That's been several years ago.
Yeah.
So
Yeah.
she started travel nursing back in probably 2000, 2001. So
Okay. Yeah, that was a while.
it's been a hot minute.
And she just retired.
Really?
Just retired.
Holy cow.
I just
Just
did
last
her,
month.
took her Calico Rock route. So.
But yeah, I mean, people would call in, snow, and some of the moms load us up, bring us in, and I mean, I helped give baths and clean. I never forget I dropped someone's dentures. I'll never forget that as long as I live. But years
How old
ago, it
were you?
wasn't. I was probably like 12, 13.
Oh, my goodness.
So, or my mom would get called in the middle of the night. So my dad was always gone. So she'd haul us. So I think it was room 134, 138. Slept in that room many nights.
Swing that hallway. I've slept there. I did registration before billing. So swing that hallway. I think we've slept there a time or two.
Yeah.
Stayed many nights in the hospital.
Oh, yeah.
Thank you guys for having us.
Thank you.
We appreciate y'all. Thank you for all you do for the community and the
And
hospital
even if
and-
we don't get a referral out of it, if we can just help you help somebody,
Yeah.
that's even more than happy.
Yeah. Well, that's why I mean, I think this, even with the questions coming in, Allison said thank you too, and so did Mike. You're getting 22 new best friends
Yeah.
because we're gonna have a lot of questions.
You can
on
give
our
them, you
questions.
can give everybody my cell phone number.
Okay.
I'm on calls all the time, so if you're better off just text, be like, hey, this is Tasia, call me.
Okay.
I got a question.
Okay.
You got my number
Yes.
too. So do y'all have like a, say a case conference type deal and talk about the patients or people y'all picked up? Oh, okay.
That's what I think where Terry's question was coming from.
Oh, okay.
We, our billing, which our, Baxter's actually taking care of our billing and stuff now.
Oh, okay.
And our, system that we actually put our EPCRs in is a little archaic. And so our director has to go through, like if we were looking at falls, he would have to go individually by year
Mhm.
and
So-
count how many falls.
Do you guys participate in AR share?
I haven't heard that. I'm not sure.
We finally.
What is it?
So it's like a database. So depending on your EMR, it like I think you have to pay to be on it, but there's
Then that means no. We
several, but like,
we're
like so say we get hey, this patient needs help because doctor get the order, we can just get on Arkansas Share, and if whoever these doctors that participated in it, the hospitals that participated in it, we can just go in there and get data.
Okay.
So
Okay. I can ask our DON about that and see.
and if they don't, I don't think it's terribly
Do
priced.
it's expensive. Yeah. I'm sure Baxter does.
I bet they do.
Yeah. So it's probably.
Yeah.
Thank you guys for having us
Thank you,
again.
guys.
We appreciate y'all.
Sorry if I wrote up bad memories.
And I'm gonna leave this popcorn here too. I think I'm here for all of it.
Thank you.
Bye, guys.
Bye.
Have a good day.
All right. That is our last presenter of the day. I want to thank everybody for joining us in Zoom land and being in the classroom. I think today was very informative. Oh, look at the little one. Hi. I will have this information in our office, and I will try to get some of the information in our protocol books. That way we have it local and easily accessible on our trucks. As Allison mentioned, when we have so much posted on the walls and the trucks, it gets a little overwhelming. So
Hope you learned something, and I hope that you will join us again next week as we get some more information out there.
Thank you.
You're welcome. Thank you.
All right, bye.